Perfect. Thank you. So just some introductions. As you can see, there are many members from our various teams who will be working in all the different aspects of the clinic and the clinic workflow in order to ensure a successful transition to the system. So we have representatives from the ambulatory team, surgery clinical informatics, medication management, provider education / adoption, as well as the order sets team. And on behalf of our extended team, we'd like to welcome all of you again from the clinic joining us today as subject matter experts, or SMEs for short, which I'll get into in just a little bit. But wondering if I can invite those from the clinic to please introduce yourselves, including maybe your role and if you've had any prior experience with Cerner before. Anyone like to start?
I can start. I'm Neil. I'm the patient care coordinator for ambulatory care, and I've had a little bit of experience with CST as some of my other clinics have gone live already.
Hi, I'm Pinky Batanga, the administrative manager for ambulatory care. I've also had previous experience with Cycle 2, which I think there was about 4 or 5 clinics that went live in July.
And I'm Amy. I'm just stepping into the ambulatory nurse educator role here. I've had some experience going live with the clinic that I'm also working at. It's the gender surgery program here.
Hi, I'm Aubrey. I'm the clerk here in the Burn Clinic. Unfortunately, I don't have experience with Cerner as our clinic is just with AV. Is my mic working?
Yeah, we can hear you.
Okay, perfect. I'm Selena. I work as an RN in the surgical outpatient. I've done bedside nursing when Cerner actually rolled out in the hospital. So I've probably had a fair share of experience with Cerner already, with entering orders and all that jazz. Yep.
Perfect. We miss anybody? That was everyone. Yeah. Okay. Perfect. So the agenda for today will include an introduction to what CST and the project is all about and what your role is being subject matter experts, and then just jumping right into identifying any gaps and discussing the workflow for your clinic. So the purpose of these meetings, there are a series of meetings that are held to ensure proper design of the clinic. And today's session is to allow us to ask questions and explore your current workflow, identify any knowledge and system gaps, and provide you with the opportunity for inputs for your future state workflow. So what is CST? It's the Clinical and Systems Transformation Project, and it aims to transform healthcare systems and processes to improve the safety, quality, and consistency of patient care. The health organizations that are involved in this project include VGH, PHSA, and PHC. And the guiding principles within this project, we have specific principles that we operate under. Number 1 is with the existing system and workflows in place, we design for change based on requirements that align essentially with safety, regulatory, financial, and content, meaning that the design for the VGH Burns Clinic would need to adhere to these rules in order for us to build. So which leads us to guiding principle number 2, which is our focus is on enterprise design. And enterprise, you'll hear us use that word quite a bit if you're not already familiar with that. It's essentially what the design is that spans, or the template that spans over the health authorities, all of the health authorities that's involved with Cerner. And we always aim to be able to standardize and work for best practice when we're building for enterprise, just so we account for all the different aspects of the workflow, which can be translated across the system. And number 3 is that the system is not perfect, and there will always be something that can be optimized or improved. However, our priority for the moment is for the clinic is to build all the essentials so that it will be able to have a successful go live. So again, there will be plenty of opportunity after to kind of tweak the build, especially if there's process changes, workflow changes, and so forth. But our focus today at this stage of the build is to focus on the must-haves for the clinic. So the role of the SME. So how can you help us help you, essentially? So as subject matter experts, you're contributing as an expert and a representative of your area to be able to discuss workflows and recommendations. You understand and think strategically about the processes and workflows within your clinic and able to consider the requirements and the needs of the groups across enterprise. You are familiar with your VCH policy and documentation and able to confidently make informed decisions. You're able to collaborate with your clinic team to help inform the design and also then communicate that design and that outcome of these meetings and the impacts that it will have for your clinic. So it's a big responsibility to be a subject matter expert. We'll be working closely with you as this clinic goes live. And so we are looking forward to that. So what is this enterprise workflow? So essentially on a very high level of what this workflow is typically for clinics is a template of what we follow and what we build for. So of course, there will always be little nuances that are specific and we can discuss those and what those are for your clinic as we move through our sessions. But just for a quick high-level overview of what that template looks like, usually starts with a referral. So from step 1, referral can be received externally, which is typically through fax, or internally, which are orders that are received in the system to schedule an appointment, and again, done within Cerner itself. So referrals are then screened and triaged, and it can either be accepted or rejected. Once it's accepted, scheduling process takes place in the system where patient confirms the appointment. So on the day of the clinic visit, it will include a patient check-in and the registration, where the encounter will then fully be activated for that patient's visit. Next, the patient is seen by the clinicians, so nursing, allied health, and the providers in the clinic, ensuring that we meet documentation needs, which are not only site policy, but regulatory requirements as well, as we had mentioned earlier. So clinic procedures can also take place during this time, including medication administration, any minor procedures and treatments, which again have an equivalent in Cerner with regards to how they're ordered, how they're entered, how medications are signed for, and how they're documented. And finally, the patient visit is complete and follow-up visits are scheduled as well. Prescriptions, labs or diagnostic requisitions can be sent out or printed for the patient. And then that encounter for that visit will then conclude and will be discharged. So I know it's a lot to take in, but those are kind of high-level overview of the steps of what a typical clinic enterprise workflow would follow. I'm just going to stop there. Is there any questions at the moment? Anything glaring? Okay, great. Thank you. So now we'll move on to the meat of this meeting, which is our gathering session. So just basic general clinic information. Thank you for filling out that questionnaire that was handed out. And we had some of this information from the questionnaire as well as the site visit that we had conducted a few weeks ago. And if there's any information on these slides that are inaccurate or not correct, please let us know. But essentially what the format will be is a portion of the information that we do know. And if you are able to confirm that, and then any little details that we haven't yet garnered, and then we can ask those as we go through along. And the process of these questions will follow what the workflow would be. So again, please feel free to jump in anytime. So what we know about the clinic is that they're open on Wednesdays, once a week, from 8 to 12. You utilize paper, email, fax, and telephone. The PAC system as well as PCIS currently. You see adults, no children, and they're all outpatient visits. You have physicians, a physician? Is it just Dr. Pap? Yeah, okay. Multiple RNs, 2 clerks at the front, the private MOAs, and an OT. Is that pretty accurate? Okay.
There's like residents, med students as well that we work with. in the
Okay.
clinic.
We'll take note of that. Thank you. And you have 1 phone number and 1 fax machine, and those are the numbers that are there. So I'd just like to confirm that your clinic name officially is the VGH Burn Outpatient Provincial Program. Is that correct?
Has Dr. Pap weighed in on the name?
No, oh, sorry. So I meant to say that earlier. Dr. Pap, because of scheduling conflicts, he couldn't make it to today's session. So we are meeting with him in the middle of March to do his separate review.
Okay.
So yeah, but we haven't touched base with him yet.
Okay.
I think, Lavelle, I think there was a preliminary, like pre-design meeting with Dr. Pap regarding this before any of us even started. So I think this naming convention has already been floated by him, but we'll confirm on our end and let you guys know.
Okay.
Okay, then we'll move along. Is the phone or the fax number shared with other clinics, or is it specific to burns?
It's a specific for brain, but Glasgow and the resident clinic is using that fax and phone number as well.
Sorry, so it's shared with.
Shared with ortho trauma as well.
Okay. Okay, thank you. Just future state, we'd have to figure out what your clinic would like in terms of what to do with your future fax number. Are there any specific like clinical reports or data required that are routinely pulled now that you would need in future? Anything different that is not available already? I don't know if Pinky are aware if there's anything different for this clinic that they would need. No? Everything's pretty much there. Yeah. Okay. Hey. So for referrals, we know that it comes from anywhere that has that fax paper form, which is from ER, urgent care, private GP referrals, and as well as the burn inpatient unit at VGH. You can schedule these patients up to a month in advance. You don't keep a wait list. Essentially, you receive the referral fax, and then you pretty much schedule them into the slate. So just question of, can these patients self-refer? Are they always requiring a referral from a physician?
They cannot self-refer.
Perfect. And this is that referral form that I mentioned about that everyone that you would receive. Is it always by fax, or is there more informal ways to refer a patient? Do you always need a fax for scheduling?
Yes, we do need to receive the paper referral. Then once we receive it, we'll book them in. If they're from urgent care or from physicians, like family doctors, walk-in clinics.
Thank you. It might just be my audio, but it's a little muffled. Are you able to take notes, team, Eric, if that's okay?
Maybe
Okay.
you just repeat that. Yeah, it is a bit muffled on my end as well.
Aubrey, I'm gonna get Laura to get you a speaker so it's a little bit more clear.
Okay, sorry. I'll repeat it. I remove mine. So, how we receive referral is either by fax when it's from urgent care, and then if the family doctor refer the patient as well by fax.
Perfect. Thank you.
Is it better?
Sorry, can you repeat that?
Is it better the sound without the headphones? Because I removed the headphones.
It's touch and go there a little bit. We'll do we'll do what we can.
Laura's on her way. Laura's on her way to give you a speaker.
Okay.
Oh, there she is.
Sorry.
All good. Technology.
Hello, can you hear me better?
Yes, that's amazing.
Okay, thank you. All good. Thank you, Laura.
All right. So next question, I guess, is still for you, Aubrey. In terms of when you receive these referrals, and then you schedule them in, do you ever reject any of them? Are there ones
No,
that you don't
no,
schedule?
we're not rejecting any patient.
Okay. So pretty much as soon as you get the fax, they're just automatically scheduled in.
Yes.
Okay. Are there faxes that you get that are incomplete? Like, do you need, if more information maybe, or that doesn't matter? As long as you get the fax, you'll schedule them in.
As long as it's mentioned that it's for burn, it's related to burn, I schedule them an appointment.
Okay. Okay. Perfect. So not really too much of a triaging process. It's just fax to schedule. Okay, perfect. So for the visit itself, the patient will arrive at your desk and then you will check in. You don't armband your patients currently. There is no primary intake questionnaire that they complete. But you do print out a patient list for the day, kind of acts as your slate. Is that all correct?
That's right. And when they check in, I usually ask them if they're interested about the burn fund. And if they said yes, I'll just give out the form for the burn fund, then we'll fax it over to the burn fund clinic, and then they'll contact that patient if ever they need resources.
Okay. We will double check if that's going to impact anything for us. Do you do any other screening for them? Like, do you have any questionnaire for COVID, or do you take any other information like allergies?
No, we don't usually, us clerks, we don't do that.
Okay.
Thanks.
Yeah. So when you schedule them in, when you receive the fax, are there ever any instructions like requisitions that you have to tell the patient to get done, or any sort of pre-visit work that needs to be completed by the patient before they come in?
No.
Okay. And do you ever get patients, like if VGH burn inpatient unit refers to you, they're not currently inpatient, correct? They've been
That's right.
discharged. Okay,
That's
so you
right.
never see.
We're not taking inpatient patients.
And I would assume then there's no walk-ins.
No walk-in. It needs to be like by appointment.
And then the patients, when you have registered them fully, how are they brought into the bays? Like, what does that process look like? Into the different slots in the unit.
You mean by when we schedule the appointment, right?
No, so when the patient arrives and you've already registered them and they're waiting to be seen, how are they brought into the clinic space? Like, how do the nurses know to get the patient?
So,
Okay, Aubrey, you can go.
okay. I think Selena knows more about it because once the patient check in, we usually ask if all the information in our end is right, and then if they said yes, and then we'll just put the chart in like a rock, and then that file rock, that's where the ready patients, and then the nurses will just bring them over.
Yeah.
Okay, is there any process to that, Selena? You just take one from the rack and then you just put them in whatever slot is free?
Yeah, so with burns, it doesn't typically get backed up, but we do base it on the time of their appointment. So in burns, there's really not many X-rays, but say in other clinics, the X-rays kind of jumbles up the appointment. So like we try to get the 12 o'clock appointments in, say if somebody was at a 1 o'clock appointment, we try to keep that in mind. But burns, we usually don't have problems. It's a
Okay,
pretty good flow for the most part, I would say. Um,
okay. Yeah, yeah, so we're trying to see if we can mimic that process in the system because it won't necessarily be it won't be paperless, but it'll be paper light workflow. So in terms of the process of you having the rack to refer to for the charts, so we can discuss that a little bit further about what that would look like in the future. Okay. And then is there for when the patient leaves after their clinic visit, is there any sort of formal discharge from in terms of like administrative clerk wise? Is there something that needs to happen?
No, once they're done with their appointment, if they need to follow up, they have a little paper. They'll just give it to the clerk and then it's stick there when they need to follow up. It's either 1 week, 2 weeks, or 3 weeks. Then we'll just reschedule them for the next visit.
Okay. That piece of paper comes from the provider? They just manually write out?
That's included in the chart because us we prepare it, right? And then we have like we put like a little follow-up paper there, and then once the doctor needs to see that patient again, Dr. Pap will get that paper, and then Dr. Pap will think when that patient needs to follow up, and then that
Okay,
paper will be given to us clerks, and we'll schedule them again for the next visit.
perfect. Hey, so just moving along, there's an average of about 25 patients, essentially. Oh, hi, Michael, just jump in.
Me. Back to the referral form that you showed earlier. Just a question for the group. If the referral comes from a UPCC or a primary care location, is there another form that they're using, or how are you notified? Like what kind of form are they sending you?
If it's from the family doctor, they're just using their own form. There's no specific form. So mainly this one, that form, I rarely use that form for the burn clinic. Usually that's for plastics clinic.
Okay. Okay.
Okay.
Okay. I'm just going to pause here and I'm going to introduce my colleague, Tommy, who's going to be doing the next few slides with you.
Hello, everyone. I'll take over. Lavelia has to drop off for a little bit and she'll come back. Okay, so we have more questions for the clerk. So what we know here, average, we're doing 25 patients a week, and the appointments are scheduled for as 1 month in advance. And then so far, we're seeing that you have one appointment type. It's called the burn follow-up appointment type. Do you use any other appointment type?
I think that's it.
That's it? Okay. All right. Moving on, and how do you communicate appointment information to the patients? Like once the appointment is scheduled, do you call them or what is the process?
When I receive the referral, I call them based on the urgency. And sometimes when they refer a patient, it's mentioned there when do I need to book the appointment. If it's urgent, it needs to be booked on the next following appointment of the doctor. And for example, we'll just follow what's written in the referral.
Okay, but you will always call them after
Yeah,
you
I'll call them
schedule.
to
Okay.
let them know about their appointment.
Okay. And do you use any kind of appointment reminders?
No, we don't. But sometimes if the family doctor asks that, we usually fax it because we're not doing text or email reminders.
Okay, would you be
Just by
interested
fax.
in an automatic appointment reminder?
I think that's good idea.
Great.
Yes, I believe so.
Okay. And do you when would you send down a patient chart to health records?
If the family doctor requested a copy.
Also, you don't always send chart to health record, you keep it in the clinic.
We CC the family doctor because when we register the patient in PCIS, there's like a part there who's the family doctor, and then if the patient has a family doctor, we usually encode it there, and then I think the health records automatically send it to the family doctor. I'm not sure about that.
Okay, but
But
in
I think
terms
that's
of
how
like,
it works.
oh, Michael, you have a question.
Yeah, I was just sort of wondering, for patients with historical records that belong to your clinic, do you hold on to those file folders somewhere in the clinic physical space, or are those file folders sent somewhere for scanning or for storage at some point? Thanks, Neil. Go ahead.
We just keep the actual paper for 1 year. And then after that, we discharge it and we send the way how we discharge the charts is we just keep the written ones, the one not in Cerner or PCIS. Then we send it to to HR. Did I
That's all
answer
I
your
was.
question?
Yeah, that's all I was going to say too.
Yeah.
Have
Okay.
just for since we do have Pinky on the call, is that process changed for other clinics that have gone? Just so we can make sure we don't.
Did that process change? Sorry.
Yeah.
No, we do have for the ones that have gone live, we do keep the charts for about a year. And so of right now, we are doing cleanup for the clinics that went live in cycle 1.
Okay. Okay. Thank you.
Okay. Next question is about the follow-up, and then I think we have this answered already. And how does the physician know when the patient arrives? That's our next question. Do they look at the rack that you were talking about, or?
Yeah, we have a kind of a visual chart system. So when the chart, we'll have a rack of charts that all the charts will get put in order, and the doctor is just pulling the charts one at a time out of the rack as they're sort of to be seen in order.
Okay, so the physicians, the nurses, and the OTs, they all have access to the chart. I mean, the rack.
Yeah.
Okay, and do you have to track patients' preferred pharmacies?
No, like I'm not sure I understand that question. Like, do you need to track patients' preferred?
There's a way in our system where if you save a patient's preferred pharmacy to their profile, when you write a prescription, you can actually have it automatically faxed to that pharmacy when you sign the order. It's a new configuration that's available, and so if you guys track that, then it's historical information that's valuable to keep using.
We don't do that currently.
Okay, thank you. The other question I had was. One of the other questions is, so historical documentation that doesn't belong to the clinic, do you guys ever call for an inpatient chart to be brought to your clinic physically, like a discharged chart? Like say the patient was a recent inpatient, that chart isn't discharged, but you need to bring it to the clinic so you can have it when the patient shows up, or no?
That would be pretty rare. I'd say
Okay.
no. Yeah.
Okay.
Okay. Next, if the patient is a no-show and who is notified and is the appointment rescheduled?
So if the patient no show, they'll for us to reschedule them, they need to give us a call. We don't call them to say, hey, you no showed and then they want to reschedule. They need to call us for us to
So
reschedule
if the
their
patient
appointment.
doesn't call, you don't reschedule.
Yes.
Okay. Okay, next. Okay, moving on to Selena's questions. What we know here, so the medications they are from physician's orders. You do not use Omnicell. The porters are paged ad hoc to collect specimens as needed, and there's no lab work collected by the nurses in the clinic. And there's no patient phone call follow-ups done by the nurse. And the charting is complete on the nursing flow sheet, which I'm going to go over in a bit. And the nurses perform dressing changes, the debridement, compression garment fittings. And here are a couple questions that we would like to know. Do you document any allergies, home medications, or any patient histories?
Yes, so we do document the allergies, not so much. And like in terms of home medication, say if we're giving them Tylenol, we just want to know what they've taken prior to it, but not so much home medication.
Okay, do you document this anywhere?
So we have an allergy form that we fill out.
Okay. Okay, specific allergy form. Okay.
Yeah.
And in
I think
terms
it's
of
the same. Sorry, I apologize. I think it's the same allergy form they use on the inpatient side. It's just that we didn't capture it because it's the same elsewhere.
okay,
Yeah.
all right.
Could
And yep, go
I
ahead.
just go back to under dressing changes, wound debridement, compression garment fitting? Just that the compression garment fitting actually fits a bit better under the OT rehab.
Okay.
Yeah.
Okay, we can change that. Okay. And do you have a list of the medications that nursing usually gives, include a route of the medication?
So
what are some common meds?
Like hydromorphone and Tylenol. We have like a booklet that shows kind of each dosage that we, each medication that we give, but typically Dr. Pat would say hydromorphone, 1 milligram, for example, for the smallest dose first, and then usually it's oral.
Okay.
We do have Narcan there as well if we need to use the Narcan kit. But we do have the locked up med container for the nursing station. Yeah.
Okay, thank you. Okay, what type of specimens do you collect in the clinic?
So mostly swabs. So we would do like culture and sensitivity swabs. And then I think that's mainly like the main one is CNS. Yeah.
Okay. Do you need a requisition for your specimens?
Yes. Yeah.
Okay.
So
And
we would fill out the form, and then we would send it to. Well, we would give it to Aubrey, and then Aubrey would, the clerks would send it.
okay. And what are some common orders received in the clinic from Dr. Pat?
So aside from like dressing, are we talking about like dressing changes?
Any kind of order, like medication order or dressing change orders?
So in terms of medication, sometimes there's like a few medications like Flamazine, Bioderm.
Okay.
There's just specific ones that we would do with the dressing change. So those are done prior to, or there could be orders or like administer pain medication prior to the dressing changes. there could be specific dressing changes that he wants us to do for that wound. And he would typically specify, say, like, we want to widen this small section, or like put acetate on this small section, but do this to this section. Just put a MetLife border. So it's very specific in terms of like what he may ask for. And usually we like to go in with Dr. Pat and the patient there, so we can actually kind of see from the beginning of what they were discussing and what he wants done. At the end, we try to, but it's kind of hard to be there.
Okay, Neil.
I have a feeling, and you can double check this with Dr. Pat, that you might be able to build a couple of generic wound care orders, because there are a few things that he orders all the time. Like if the person is not going for surgery, he'll have like a specific kind of dressing order that he would do all the time. He would say like double layer Acticoat dressing, follow up in 1 week. And then if he's going to do see someone for surgery, he would say Flamazine, return to clinic next week. So you can check with him about, there's a few things I think that he can be very generic, that he can just click on, and anything outside of those orders he could add in more detail.
Mm-hmm.
Okay, perfect. Yeah, well, I think we're gonna probably build some kind of quick orders for those commonly used orders, so you can just click.
Yeah.
Yeah, okay.
In this scenario where he's like, because sometimes he'll ask for like, there's this big wound, and he'll be like, I just want pomegranate here, and this small section is this. Is there a way, I guess there's really no way for him to specify that order, or is that just something that would
So does he usually just give you like verbal orders, or would that be like a written?
it's
order?
verbal, and he will like say just, he'll like point it out for us to be like, I just want Vigram here, and then pomegranate right beside it.
Okay.
It can be specific, but most of the time it's double layer Acticoat, that protective dressing.
Okay. We'll have to figure that out. Okay. In terms of any point of care testings, do you do any like glucose, any urinalysis, anything like that?
No. Okay.
And do you make any kind of phone calls to patients in between clinic visits?
No.
Riza, I see you have your hand up. Sorry, did you have a question?
Oh, yes. Yeah, sorry.
Oh yeah, this is Riza from Order Stats. Just wanted to let everyone know we will be discussing with Dr. Pap at a separate session, and he might want to build a power plan with a list of the most common either dressing change, pain meds, swabs, all in one. I know the pediatric population has one for the ambulatory space for burn dressing changes, so it might be beneficial for the clinic as well. But we'll discuss that in detail with him. But it's good to know you guys are receiving kind of a mix of all those orders. Then we can kind of create a tool that would make it easier for the ordering perspective.
Okay, thank you, Riza. Okay, in terms of documentation, do you do any additional documentation aside from the flow sheet, other than the flow sheet and the allergy sheet you were saying? Do you do any like narrative notes?
Sometimes the comments we just kind of write out.
Or like on the comment section here. Okay, I see.
Yeah.
Okay.
But most of the time we just kind of circle the donor site location, and then tick mark the like the type of dressing that we use and to which limb and which body parts. Yeah.
Okay. Okay, great. And how many nurses are there per clinic shift?
Minimum 4, I guess. But
4 at the same time?
It depends on the week, because
Yeah.
some of my coworkers get pulled out to different areas that Neil was under. So
Currently, it could be anywhere from 4 to 7 nurses.
Oh, okay. All right, thank you.
Hey, sorry, can I ask one more question about the meds too? I think I noted on your questionnaire that you guys administer cortisone as well. Is that just the provider that does it then, or and would the nurse be doing any cortisone injections as well?
no, it would just be
Okay.
the doctor.
Okay, thank you.
Okay, so we're going to go through this with Dr. Pap in our later sessions. I do just have a quick question here. Do you know if Dr. Pap provide any kind of patient letter to the patient before they leave?
I don't think so. Like not.
Like a standard
No.
visit? No. Okay. Okay, we'll go through this later. Okay, good. All right, and next up would be OTs. I believe Lisette is here. Okay. And could you briefly describe your workflow?
Okay, this is me now. So for whatever reason, my camera's not working. So the outpatient rehab group is actually not currently in charge of burn clinic. It's like a weird historical political thing. I think it's the inpatient OT burn therapists who are not hand therapists, to my understanding, that are currently doing it, but I don't think they're involved in any of the CST stuff. So they typically use this referral form, I think, from Dr. Pap. I think it's similar to what we would do for either hand, like plastics or ortho clinics, where they just wait for a referral from Dr. Pap and then provide the intervention. The appointments they are not seen in our rehab department. They are seen, I think, just at follow-up in clinics, because I don't really know what their burn therapist does. If they are referred, so we just have a few patients that have been referred from burn clinics by a covering therapist or like their practice coordinator. Anyway, long story short, they have hand burns or like frostbite, and so they, I guess, are going to be considered as plastic patients. So this same referral sheet gets used and faxed over to us. In terms of communicating follow-up schedule, that's typically done by the therapist to the patient. Like our clinic will contact you from the phone number that's provided there, and then the receptionist will reach out to them. Typically, though, with most burn patients, our receptionist had nothing to do with it. So I think it really is only if it's like hand specific, they need splinting or ongoing wound care needs or whatever. And then in terms of orders, I just assume that it would be very similar with Dr. Pap, what the other surgeons do that we work with. And this form is utilized pretty much, I would assume, again, anytime there's an intervention that's needed by the therapist, where like there's some sort of direction, whether it's something as small as just like scar management or education or compression garment fitting or whatever, this is going to be used. But I have never seen burn documentation in our department before. Like it's supposed to be kept separately from where the burn therapists work. Like, because currently it's the inpatient burn therapists that are supposed to see them.
Okay, great. Okay, thank you. I think that answers all the questions here. Okay. Moving on. Okay. And do you currently use this flow sheet?
I think that the burn therapists do not use this flow sheet. So if we're talking specifically about the burn clinic, I don't think that they use this.
No.
I think that so on the first sheet that you showed, on the flip side is a space for documentation that has database and everything like that. So that is typically where they would put everything in. yeah, I don't think.
So you were saying the flip side of this form, or
The first form that you had, the referral
this
form
one?
has, yeah. On the
Oh,
other
there's the second
side,
page.
yeah, the other side
Okay.
has a database or like lines for charting, essentially.
Okay, and that's the form you would use to for documentation.
Yes.
Okay. And do you document anywhere else other than the flip page?
So again, this is not a clinic under my portfolio, but I think if these patients were seen in rehab, then currently, because rehab in Jim Pattison is on Cerner, we just document in Cerner.
Okay,
But
like
again, these patients are not currently being seen by like my therapist, but there are a few that we are taking on, but they are just going to get documented how we do with the rest of the plastics patients and hand patients, which is if we do an intervention in Diamond Center, then it's that first page with the referral form and the documentation there. This ambulatory clinic assessment form typically only gets used in ortho clinics by the physio.
I see. Okay. Okay, one sec here. Okay, and the form that you're documenting on, does it have to be distributed to other clinicians?
Yes, in the sense of, so again, not necessarily burn clinics, but what we're doing now with that sheet is it's getting faxed into the work queue monitor for rehab because it's part of their Cerner chart, so that the next therapist who's treating them in the department has access to that charting note, because otherwise if it was kept separate, we wouldn't know what the first initial interaction is, or we wouldn't know what the intervention is in Diamond. So yes, like the rest of the team needs to see that.
Okay, thank you. Okay, next is about research, and we understand clinic, see about one patient, patient once a week, clinical trial patients once a week. So how many patients do you see? How many clinical trial patients a week?
These will all be questions for Dr. Papp, because the clinical trials kind of come and go. He doesn't always have a trial going, but he'll be able to answer these questions a lot better.
Okay, perfect. We'll save these for our next session. Yeah,
Hi,
go ahead.
Owen, sorry, just following up on that. Is there anything different though in the past that you've had to do with clinical trial patients, like different types of forms that you have to fill out? Just so we kind of have a heads up of what to expect. Different documentation. We
typically don't have much to do with the research patients other than their normal burn care, which would be the same as everyone else. They would have a research nurse coming in and doing something specific with the patient.
Okay, research nurse. Perfect. Thank you.
I was going to ask if there's anybody beyond the research nurse. Is there a research coordinator or any other roles that we should be accounting for people who support that?
There could be, but again, Dr. Papp will have more knowledge of that. Yeah, we don't actually have much to do with the research on our clinic side.
Okay. Next. Okay, I think that's all our questions. Do you have any questions for us? Anyone else on our team have more questions for the clinic? All right.
Don't everyone speak at once. We do appreciate your input. We understand that it's a lot of moving parts, but the flow is a fairly simple flow here. And so we're going to try and keep it that way if we can. But
Yeah, so our team's going to crosswalk all the current workflows, documentation, and other clinical requirements. And you may receive more emails from us to ask questions about your workflow. Our next session is for the scheduling requirements gathering session happening on February the 20th. And after that, we're going to have a session with the provider on the 13th. And then
Helen, I see your hand up.
Yeah.
Hi, my name's Helen. I'm with the scheduling team. I know we scheduled for February 20th in the morning. Is it possible if the meeting be pushed back to the afternoon?
Let's just see who's signed up for that session. I'm going to look at that session online here and see what's happening. That's okay.
Yeah, I'm just looking at my schedule here as well for myself and the nurses.
Mm-hmm.
The nurses aren't required to attend our scheduling meeting. It's mostly just the clerical staff.
Oh, perfect. Yeah.
Yeah.
Aubrey, do you know if you have a clinic in the afternoon on that day on the 20th?
I'll double check. Give me a moment, please.
It-
What time is our meeting again on the 20th?
It was booked for 9 to 11, but I'm hoping to maybe push it to 1 to 3 instead. So same as today's
Don't
session.
you have a plastics clinic in the
Yeah,
afternoon as well as a
plastics
trauma clinic?
clinic afternoon.
Dr. Davison is usually that afternoon.
Thank you.
Yeah, we have
Oh.
afternoon and morning clinic.
Because providers aren't needed to attend as well. It's just mostly clerks or managers.
So Aubrey, you do have clinic that whole day?
Yeah, but I think Mojo is here, so Mojo will be able to help out Jesslyn. So it's all good.
Okay. So yes, we can schedule it for the afternoon.
Okay, thank you.
Great. Is there any last minute thoughts or comments or questions? Okay, I think that's all that we have for you today. Sorry we booked you a little bit too long, but hopefully the extra time will be better. So we will see you next time. Thanks, everyone.
Thank you. Bye.
Thank you. Bye.
Bye.
Thank you.